going to be talking about melanoma. So we're going to try to make this case-based, so it's applicable to kind of patients that you'd be seeing, either with us or maybe in your own clinics. First case is going to be adjuvant therapy discussion, really how we manage an early stage or new diagnosis of a melanoma patient, and then what we go through with the steps for them. Case 2 would be frontline treatment in a metastatic melanoma patient, so they present with disease that's spread hematologically to the lungs or other areas. And then case 3 is more of an evolving concept of neoadjuvant therapy, much like has been used in breast cancer. And then throughout this, we'll talk a little bit about immune-related adverse events. These are the side effects that we see with the immunotherapies for melanoma as well as other disease types. So taking a step back, it is important to recognize that there are classic and atypical presentations of melanoma rising from the skin. I think most of us are familiar with the abnormal nevus with dark pigmentation, large size, evolving. So the figures off to the left are fairly classic. But we see patients that come in with melanoma that doesn't really fit those pictures. Sometimes there's no melanin in it, so they're amelanotic, or they have unusual colors. They're red or blue. So an evolving lesion really needs investigation, even if it doesn't clearly look like a typical melanoma. And then the other part is melanoma is not just a skin cancer. It can arise in various areas of the body. During embryonic development, we have melanocytes that migrate throughout our bodies. They lie dormant, play various roles, and can eventually emerge as malignant cells and form a cancer. So in these cases, we have acral melanoma. It's occurring under the fingernail or subungual. We have mucosal melanoma, the upper right. So that's the pigmented area in the mouth. We have uveal melanoma, these two lower fields. So this is occurring in the choroid of the eye. It can be more anterior, as in the lower left, or more posterior, as in the right. We also have patients that develop melanoma on the conjunctiva, so the outer lining of the eye, and that can just look like a red raised irritated surface. It doesn't technically always have to have pigment. So it's important to keep in mind that there's various forms of melanoma. When we talk about melanoma, though, we normally think about it in the context of the skin cancer form of it. That is what is the majority of our cases. These are melanocytes that are in everyone's skin. They live right at the epidermal-dermal junction. And if those cells become malignant, they will usually undergo a radical growth phase where they grow out, and then a vertical growth phase where they grow down. Once the melanoma cells cross into the dermis, that's considered invasive melanoma. If it hasn't crossed that epidermal layer, then that's what we consider in situ. So it is a melanoma, it is cancer, but it's not invasive. Stages 1 to 2 are where it has not left the skin area. It can grow fairly deep and still be stage 2. But until it gets to the point where it spreads beyond that area, then it would not be escalated to the stage 3 category. Stage 3 is where the cells migrate from the primary spot, trying to get to a draining lymph node basement. This is through the lymphatic channels. In this example here, you can see a melanoma rising on the forearm and then spreading to the lymph nodes in the antecubital area. It could also bypass that area and go up to the axillary area. Some patients will have in-transit disease, so the tumor cells, as they're traveling, they never really make it to the draining lymph nodes, and then they stop, they form tumors, and it looks like a little BB or marble under the skin. Can feel kind of rock hard, and that's what we consider in-transit disease. That's all considered stage 3. And then when tumors have spread beyond that, beyond the regional lymph nodes, this typically is hematologic spread, but can be from lymph node to lymph node, then that's considered stage 4. Melanoma can really go anywhere. More common sites are going to be the lung, liver, distant lymph nodes, bone. About 10% of patients will present with new melanoma diagnosis and also have brain metastases. So if you have advanced cases, you can really see the melanoma anywhere. If you look at the survival for patients, this is fairly updated statistics. We have over 100,000 cases of melanoma diagnosed in the US every year. There's a slightly higher incidence in men. The mortality rate is a little under 10%, but we still have 7,000 patients dying from melanoma every year. That number is declining. It used to be around 10,000, and that's because of the effectiveness of our systemic therapies now. For stage 1 disease, the majority of patients are cured with surgery alone. The melanoma-specific survival at 10 years, 95%. Similarly, good numbers for stage 2 at 84%, although that does tell us that about 16% of patients historically have died from melanoma within 10 years. Stage 3 is quite a range. This looks pretty good for stage 3, where melanoma-specific survival is 69%, this orange curve, but there are patients that have very high-risk disease where the risk is much higher. But in general, stage 1 to 2 and 3 are thought to be surgical cases. These are patients potentially going to be cured with surgery. Risk factors include atypical nevi, high nevi count, phenotypic traits, so if you have light skin, particularly if you're Caucasian, red hair, UV exposure, so sun and tanning beds. Some patients will be at high risk because they've had deliberate UV exposure with PUVA. It's a type of treatment for psoriasis. Others have been exposed to radiation. This might be intentional. They might have had a lymphoma diagnosis many years ago, and now the radiation effect is catching up to them. Immune suppression, this could be a transplant patient, could be someone who has HIV that's not well controlled. And then a family history or personal history of melanoma. We know that first-degree relatives have a 2 to 3-fold higher risk of melanoma if a family member has been diagnosed. So if you have a patient coming in, you do want to make sure that their siblings as well as their children undergo routine skin cancer screening at least once they hit the age of 18. Lifetime risk overall is 1 in 40, and as I was alluding to, male predominance. It's about 60-40 for male to female. The screening has not changed in, I don't know, 10, 20 years that we really look at the ABCDEs. I guess E has evolved, but the main features are asymmetry, an irregular border, color irregularities, so if there's multiple levels of pigmentation, the size, so if it's over the dimension of the diameter of a head of an eraser, then those are nevi that we get worried about. And then, of course, if there's an evolving skin lesion, something that's changing over a period of a few months, that would make us concerned, or even if it's over a much longer time, that there can be slow-growing scenarios. The recommendations for self-exams is quite variable. Dermatology does like to recommend it. It's not technically something within internal medicine guidelines to strongly recommend for patients, but I think it's advisable for patients to keep an eye on high-risk lesions. So the general management, we want biopsy confirmation. So we typically want a punch biopsy over shave. The reason is if you do a shave biopsy, you might really just skim the surface and you might miss part of the more critical area or underrepresent the depth of it. Treatment, once you know you have a melanoma diagnosis, you do a wide local excision. So you're purposely going to take healthy tissue around the spot. For the thin melanomas, which would be 1 millimeter depth and thinner, those patients would undergo wide local excision with 1 centimeter margins. And then if the tumor is 2 millimeters in depth, then it would be 2 centimeter margins. And if it's somewhere in between, it's 1 to 2 centimeter margins. All patients with a melanoma that's over 0.8 millimeters in depth, with an ulceration or without, generally we recommend sentinel lymph node biopsy. The reason for that is once you hit that threshold, there's about a 10% chance of having a positive sentinel lymph node, and it does change the way we look at the patient case. Staging scans. So when do we get CT scans or PET scans? Generally, we do get CT over PET, but we really wait until we have a stage 3 diagnosis. And that could be someone who presents up front with palpable adenopathy or has clinical signs of symptoms with metastatic disease, or if they go through these steps and they have a positive sentinel lymph node biopsy. So taking a look at our first case, this is a patient, a 60-year-old woman, good functional status, ECOG performance status of 0. She is diagnosed with a melanoma on biopsy on her mid-upper back. Breslow depth is 1.4 millimeters. There's no ulceration, no mitosis, but the peripheral and deep margins are involved, so presumptively there's more tumor there. On exam, there's no clinical evidence of adenopathy in transit or satellite disease. In transit and satellite disease is really all the same process, just different nomenclature based on how close it is to the primary site. The pre-therapy stage, we use AJCC staging, is T2A and XM0. And the probability of sentinel lymph node biopsy being positive is 11%. There's actually online nomograms or algorithms that you can type in these details for, and it'll give you a probability of positive sentinel lymph node, and we can use that for discussion with patients. So the case was discussed at our melanoma multidisciplinary tumor board or conference. We do discuss most of our cases, particularly ones that are more complicated. I would say this one is fairly straightforward for purposes of our discussion today. What does melanoma look like? You can see that in this case, the melanoma, this is the skin biopsy. It's a shave biopsy. You know that because it's quite a linear cut here right underneath. It looks like it just shaved right through a part of it. But you can see here in the creps here with the dermal epidermal junction, you have these small cells with strong nuclear signaling. So you see the purple dots really invading deep into the skin. This is not a normal structure. So these are all tumor cells. And by a pathologist that's trained in this area, they would be able to recognize that these are melanocytes or melanoma. We do confirmatory stains to look at markers, immunohistochemistry markers on the tumor. So melan-A is one, and you can see here this bright red. All those cells are staining positive for melan-A melanoma marker, and that would indicate that there's melanoma cells that are invading deep into the skin layer. So the role for sentinel lymph node biopsy has evolved. We've been doing sentinel lymph node biopsy for 20+ years, and it really was never clear that we were improving patient outcomes. And then what to do with that data. So there's been several studies, including the MSLT1 and 2 studies, which we're going to get into, where we look at doing the wide local excision and the role of sentinel lymph node biopsy. And then originally, if you had a positive sentinel lymph node, you would undergo a CLND, which is a completion lymph node dissection. So you would remove all the lymph nodes in that draining lymph node basin. The MSLT1 study was the first one really to address, are we improving patient outcomes? Or if you did have a melanoma diagnosis on biopsy, if you just did a wide local excision and observed them closely, would you have good outcomes? At the end of the day, it really showed that survival was not statistically different. So the sentinel lymph node biopsy followed by completion lymph node dissection was not saving lives, at least in this study. It did give you information. You did know who the higher risk patients were, but it was seen that we can salvage patients pretty well if they end up developing disease, clinically relevant disease in the draining lymph node basin or elsewhere. What it really does tell us is survival. So if you're a patient with a new diagnosis of melanoma and you undergo a sentinel lymph node biopsy and it's positive, you know that you're at high risk from having a future recurrence or risk of dying from the disease, and the hazard ratios were over 2, so over 2-fold risk of having a negative outcome from your melanoma. So that's become the primary reason for doing the sentinel lymph node biopsy, so we can have more information on the prognosis side. It also tells us who are candidates for adjuvant therapy to lower the risk of recurrence. So it does serve really those 2 roles. So this patient here underwent a 2-centimeter margin, wide local excision, and sentinel lymph node biopsy. These are images of the lymphoscintigraphy. It's a radioisotope that's injected and then picked up. You can also use sort of like a hand-waving device like a Geiger counter rather than more of a computed tomography type image, which is more the standard approach where they overlay them. But you can see that the lymph node, the injected site and the lymph node here in the left lower figure are bright, and the patient underwent excision of the primary site and the sentinel lymph node. So the primary site is the upper right corner. The blue is part of the contrast that's injected for confirmation of the lymph node when they actually cut into it. They want to make sure that lymph node is blue, and then the sentinel lymph node is the specimen in their lower right. Basically, they remove all the fatty tissue, and there's lymph nodes embedded in that, and the pathologist will dissect them out. So under the microscope, the pathologist will look for melanoma. You can incidentally have nevi in the lymph node. So in this patient here, there was an incidental intracapsular nevus, that's the ICN. But adjacent to that, there was a small pocket of cells. We're talking only a handful of maybe 10 cells that were not supposed to be there. So that's a micrometastatic deposit of melanoma that's in the draining lymph node basin. This really bumps the patient up to stage 3 now. So we have, at this case, actually, it looked like 2 cells were identified, even though it looked like possibly more in that image, but the pathologist was calling it 2 cells. It's been fully excised. There's a BRAF mutation, which we'll cover in a second. Patient underwent CT scan, and there was no metastatic disease, so M0. This is how we add up all the components of the staging for these patients. The T is the primary site, N is the draining lymph node basin, and M is if there's a distant site. And in this case, this patient fell under the stage 3B category. What's the meaning of this? The prognosis of this, in this case, means that there is a fairly high risk of recurrence, probably in the 30–40% range. The melanoma-specific survival for stage 3B melanoma, 10 years, is 77%, which, if you flip it the other way, means that 23% of patients, unfortunately, would die from their disease. So I'm going to throw up some management options for patients. I'll let everyone just read through it for a second. I'll read through it myself, but why don't you think about what you would do for this patient? So would you offer completion lymph node dissection? Would you do the CLND and add adjuvant therapy? Would you just watch? Would you offer adjuvant systemic therapy and not do the lymph node surgery, or offer a clinical trial? So the clinical trial option is always attractive, although that's not the answer we're looking for here. The current standard is adjuvant systemic therapy and to forego the completion lymph node dissection. The reason for foregoing the completion lymph node dissection is that the 2 subsequent trials showed that if you had a positive sentinel lymph node and then you remove the remaining lymph nodes in the draining lymph node basin, that the outcomes were no different, that you didn't really prevent recurrences in patients or survival of patients, as opposed to just doing close observation. Close observation meant you would do clinical exam and ultrasound of the draining lymph node basin, as well as CT scans. So we find that the completion lymph node dissection doesn't clearly offer an advantage for patients. So we've really changed practice and hold off doing that. What we do recognize, though, if you don't go in and remove all the lymph nodes, those patients are at a slightly higher risk of developing nodal disease than patients who undergo a lymph node dissection. So the risk of non-sentinel lymph node nodal disease increases to about 18%, 20% at 5 years in patients that have a sentinel lymph node, but in patients that did not undergo the sentinel lymph node and completion lymph node dissection, that risk is a little higher, 26%. So at the end of the day, it just means that we might see a slightly higher incident rate of nodal disease in the draining lymph node basin if you didn't go and clear them all out. But that doesn't have a major detriment to the patient, that it's actually better to avoid the lymphedema risk by doing the completion lymph node dissection. So you're now diagnosed with stage 3 disease, and we have some very good options for patients to prevent or lower the risk of recurrence. And there's three main studies that have led to FDA approvals. This includes dabrafenib, trametinib, nivolumab, and pembrolizumab. And all three of these therapies are 12 months of treatment and reduce the risk of recurrence by about 50%. There are older therapies, including interferon and the drug ipilimumab, but we don't use those as standard management currently. I did want to take a step back just before we get too far into the immunotherapy, just to make sure everyone is on the same page. We talk about immunotherapy in kind of big topic items, but want to make sure everyone really understands what we're doing when we use a drug to stimulate an immune response against the tumor. In this diagram, tumor cells release antigen. They're picked up by dendritic cells, which are antigen presenting cells, and they're processed and then presented on MHC class molecules. Those dendritic cells migrate to a draining lymph node. They activate resting T cells. The T cells will recognize the antigen, the tumor antigen, through TCR, or T cell receptor recognition. When that happens, those T cells become activated, they migrate back to the tumor, and then they have killing machinery to really wipe out the tumor cells. This is effective majority of the time. When tumors are able to escape, there's a mechanism that leads to dampening of the immune response. So these T cells that can recognize the tumor as foreign and try to eliminate it are inactivated or exhausted or dampened in some way. When we give immunotherapy, we're trying to reinvigorate this. So there's the CTLA-4 mechanism, where CTLA-4 inactivates T cells in the priming phase, typically in the draining lymph node basin. We can give an antibody called ipilimumab, and it interferes with the B7 and CTLA-4 interaction. Those T cells become reactivated. In the effector phase, this is in the tumor microenvironment, PD-1, PD-L1 leads to T cell exhaustion. So the tumor cells actually can put up a marker that leads to T cell exhaustion, and they evade the immune system. The drugs ipilimumab and nivolumab interfere with this, and PD-1 is no longer engaged, and the T cells become reinvigorated and can eliminate tumors. So the other class of therapy that I wanted to make sure we address is targeted therapy. This is more straightforward, what most of us are familiar with. And we look for an abnormal pathway in the tumor cell, in this case BRAF. BRAF is one of the RAF isoforms, part of the MAP kinase pathway. We see it mutated about 50% of the time. When you have a BRAF mutation, it drives tumor cell proliferation, survival, invasion, metastasis. And we can block the pathways. We have very selective BRAF and MEK inhibitors. We do dual blockade or vertical blockade. We hit the pathway twice to avoid a majority of the resistant mechanisms that can emerge, and that has become a very successful strategy in treating patients. Looking at the data, we know that if we offer patients a year of dabrafenib trametinib versus placebo, we lower the recurrence risk by almost half. In this follow-up data here, the hazard ratio of 0.51 shows that we lower the recurrence risk by 49%. And we see what looks like a plateau of the curve. So patients, fewer patients are relapsing even far out, well beyond the treatment time point, which ends at 12 months. Similarly, with pembrolizumab, we see a hazard ratio of 0.56, meaning a year of pembrolizumab, this is the immunotherapy, compared to placebo, we are lowering the probability of recurrence by 44%. And for nivolumab, the nivolumab study that led to FDA approval did have an active control arm, or ipilimumab, but again, it improved outcomes significantly and is an option that we offer for patients. So some of the reasons we choose between one versus the other, if the tumor harbors a BRAF mutation, you do have either one as a choice. I would point out is that the side effect profile, the AEs, adverse events, are clearly different between targeted therapy with dabrafenib trametinib and nivo or pembro. The dabrafenib trametinib, you hold the drug and the side effects resolve, although it can be very frustrating to get through a year of treatment. They can be kind of nagging side effects, such as fevers, fatigue, rash. With nivo-ipi, there are fewer side effects, but when they happen, they can be more serious or permanent. So if you're offering an adjuvant therapy to a patient, you do have to be conscious that you could cause a lifelong problem, and that patient could have already been cured by surgery. You just don't know. So you do have to be careful, and especially when you're describing the benefit to patients prior to treatment. So going back to our first case, the patient received nivolumab for 3 months, developed grade 2 immune nephritis. So this is one of the more rare side effects that we can see. And treatment was held, ended up getting prednisone, tapered off over 5 weeks. The nivolumab was discontinued. Hopefully the patient still gets all the benefit. You do not have to be on immunotherapy for very long. Nephritis recurred, unfortunately, leading to hospitalization, acute kidney injury, and hyperkalemia, but again resolved after initiation of steroids. And now I've been following this patient for over 3 years out, and no further recurrence of nephritis, and the disease hasn't recurred. So doing quite well, and the patient's still happy with her choice. So I think this is a scenario that, even in hindsight, we'd still offer the same treatment for the patient. So switching gears to a patient with active disease, so this is someone who you can't easily remove the disease, or it's widely metastatic and it's just not feasible. 69-year-old female with a history of stage 1B melanoma rising from the left thigh, develops new symptomatic left inguinal adenopathy. Biopsy, which confirms metastatic melanoma. We do some sequencing on the tumor. It's BRAF wild type, so it's not harboring a driver BRAF mutation. And the PET scan shows that there's extensive disease in the left groin, pelvis, liver, lung, so clearly not a surgical candidate. So what are the next steps? This is a newly diagnosed metastatic melanoma, otherwise fairly healthy patient. And I'll just read through them, but I want you to think about what you would offer this patient. Should you start chemotherapy immediately? Is that what we give to patients as frontline? Should you start BRAF MEK inhibitor therapy? Should you order genotyping? There might be other driver mutations, and there is some data for other targeted therapies. Should you start an anti-PD-1 monotherapy, nivolumab or pembrolizumab, or should you start nivo plus ipi? So in this case, I can say that we chose nivo-ipi, and you could have also chosen an anti-PD-1 monotherapy. But the other options, chemotherapy, BRAF MEK inhibitor, genotyping, would not be the correct choices here. So it's really D or E. And I do want to point out is that we use chemotherapy really just for palliative purposes after patients have progressed on multiple lines of therapy. And then the BRAF MEK inhibitor therapy is only appropriate for patients whose tumor harbors a BRAF mutation. When we look at the frontline trials and the therapies that we can offer patients, the nivo-ipi data really looks the strongest. We have a response rate of nearly 60%, and we have very good durability, and we have the highest 5-year overall survival rate. So that's 52%. And only 46% of patients ultimately go on to subsequent treatment. So what this is telling us that nivo-ipi is a very durable therapy and potentially producing the best survival numbers that we can achieve. Although we do have good numbers with PD-1 monotherapy, that's nivo and pembro alone, 44 to 43% patients alive at 5-year mark. The BRAF target therapy, those are the ones that are below the red bar, that's Dab-Tram, Vemcobi, and Oncobini. We see really good response rates, but durability is less, and we see slightly lower long-term survival, 30% range for most of the BRAF MEK inhibitors. So why give 2 drugs for immunotherapy rather than 1? We think there's potential synergism. You're activating T cells in the priming phase if you're using anti-CTLA-4 therapy, and then you're preventing them from getting exhausted in the tumor microenvironment if you're using anti-PD-1. So the nivo-ipi combination we think can be one of the more effective strategies. And then, as I was alluding to, the long-term survival looks great. 36% of patients are without disease progression at 5 years, so a third of patients. We know that it's probably a higher number of patients than 36% that do really well and never really need subsequent therapy. It's just not captured well in this data set here. It does come with a risk. We know that when you combine the 2 agents, nivo-ipi, about half the patients will have a serious side effect. Those are the grade 3, 4 adverse events. These tend to be autoimmune type in nature, a skin rash or dermatitis, colitis, endocrinopathies where you have inflammation in the thyroid gland, hepatitis. When you hold the drugs, these side effects do not just resolve. You have to usually hold the drugs or permanently discontinue and then give corticosteroids. But when you do that, virtually every patient recovers. And they may be rechallenged depending on the severity. The same side effects can happen when you give single agent immune checkpoint therapy, but you see it at lower rates. So if you look at the top line, nivo-ipi is 56.5% grade 3, 4 events, compared to 19.8 for nivo alone. So you do have a lower probability of a serious side effect, but you still have the same type of risk. So talking about case 2 and follow-up, patient elects to receive nivo-ipi. She now comes in for cycle 3. She has developed shortness of breath and dry cough, no fevers, chest pain, lungs are clear on exam. What is the next step in management? So this is a common scenario. It could be a different presentation of diarrhea. It could be that the labs are abnormal, but around cycle 3 is when we do see patients running into some problems. So I will read through the options here, but please think about what you would do. Number 1, proceed with cycle 3, nivo-ipi. 2, give a nebulizer, albuterol. 3, give inhaled corticosteroids. 4, order imaging of the chest. And 5, order an echocardiogram. So when you hear this presentation, you really should be thinking about pneumonitis. So the shortness of breath and dry cough. So it sounds like it could be pneumonia, but there's no cough, no fever, so it doesn't quite sound like it's infectious. So then what would be the next step in management? You have to look at the lungs. So imaging of the chest, normally a CT chest. You can start with a chest x-ray, but the resolution is not going to be good enough to see some of the ground glass opacities that might occur. You would also hold the treatment. You wouldn't want to give nivo-ipi if you thought there was a serious serious toxicity. So just as a common way of looking at this, immune side effects take a few weeks to show up from the first dose. They're not necessarily tied with each dosing. So it's not like chemotherapy where patients get a side effect, whether it's fatigue or nausea, right after the treatment, and then it gets better after a few weeks. There's a honeymoon period from start of treatment. Then once the immune system is revved up with these immune checkpoint inhibitors, then the side effect risk really shows up around week 3. And then it starts to fade once you hit week 12, week 14. So if you make it through that period, then you're likely to not have a major problem. But if someone's coming in after 2 cycles, so that'd be around week 6 of nivo-ipi, you have to be worried that this is an immune checkpoint inhibitor toxicity. So in immune-mediated pneumonitis, it's important to check for respiratory symptoms, check oxygen levels at each visit. When you suspect the pneumonitis, you have to hold the treatment, order a CT scan. Grade 2 level is where you have just minor symptoms and radiographic findings. So you can see this dense immune infiltrate in the right lung in this example. If you had this would be at least grade 2 pneumonitis. You would potentially admit the patient if they were having trouble maintaining their oxygen sats or if they were tachypnic or other more distressful signs symptoms. But you would hold treatment and administer corticosteroids. The taper is over 4 to 5 weeks. If this is a grade 2 pneumonitis, you could, in theory, re-challenge. If it's more serious, you would not, or if it's a prolonged recovery period beyond the 1 month steroids, then you certainly wouldn't re-challenge. So just as a side note, our patients get admitted to the hospital quite often or seen in the emergency room for immune-related adverse events. These are the immune side effects. There are clear guidelines on how to manage them. This is a really good reference if you are potentially dealing with an immune side effect. This is the ASCO guidelines. This is what we follow. There can be some confusion sometimes when patients enter our hospital system, either through the ER or admitted to the inpatient service. But we generally will hold immunotherapy. You should call the oncologist. If it's pneumonitis, certainly involving pulmonology makes sense, but that probably isn't the first call if you think you need to give steroids, because you really want to work through the oncologist and make sure we follow the guidelines. If the patient is in serious trouble, that would involve all services at the same time. Corticosteroids, pretty straightforward, 1 to 2 milligrams per kilogram of prednisone, or the daily equivalent, and then taper off over 4 to 6 weeks. You start the taper once you see improvement, so it's not necessarily a set time point for every patient. And then we do have other immune modulating agents if there's no improvement. So sometimes we'll add infliximab or TNF inhibitor, add a mycophenolate. There's other drugs we certainly can use, because not every patient recovers over the 4 to 6 weeks as planned. So just to follow up, this patient was diagnosed with grade 3 immune pneumonitis. This is someone that you potentially would admit to the hospital, might need oxygen support. Nivo-Ipi is held, permanently discontinued, treated with prednisone, fully recovered, steroids are tapered off, and then we held further immune therapy. Patients, we know that even after 1 or 2 cycles of immune checkpoint inhibitor may have all the benefit, that they do not need to continue on therapy, and re-challenging them can be very risky, that they may have a flare, significant flare of the same side effect, and not fully recover the same way they did with the first course of steroids. So the last case that I want to talk about is an evolving field, and this is really following suit with what we've seen in breast cancer, where patients with a new breast cancer diagnosis, a palpable mass in the breast, typically are given chemotherapy up front for several cycles and then brought to surgery, and they use that to help guide management decisions. So much like that, we have now pursued neoadjuvant approach to macroscopic stage 3 melanoma. So a melanoma patient comes in with palpable adenopathy would be the most likely example. In this case, a 70-year-old male, good performance status, had a prior history of an early stage melanoma, now comes in with palpable axillary adenopathy. This is where the lymph node would recur if it's likely to recur. Staging scans show a 5-centimeter soft tissue mass in the left axilla and no other disease. So we discuss these types of cases at our tumor board. And these patients really do have various treatment options. You could pursue a therapeutic lymph node dissection, and you could do that alone, although that's not advised in general because that's a high-risk stage 3 scenario. You could do a therapeutic lymph node dissection and followed by adjuvant therapy. I would say that's probably the standard approach currently. And what is now evolving is a neoadjuvant approach. We give a few cycles of therapy and then bring them to surgery, and then very likely give them therapy afterwards. Or you could say this is not a good surgical case. Sometimes it's more advanced than what we just presented, even though it's still stage 3, and just use systemic therapy alone, and that may be appropriate in certain scenarios. But why would we give the neoadjuvant therapy if you can just take it out and then follow patients and give them drug therapy if you need to? Shrinking the tumor might decrease the morbidity, so it might make it an easier surgery. If you start with the drug therapy up front, you're not losing time, so you hopefully will prevent distant disease spread. And then there's some thought that immunotherapy works better if you have more tumor intact, that the immune system will recognize the tumor more effectively as you stimulate it, and then those immune cells will be able to spread throughout the body and look for micrometastatic disease that might be hiding elsewhere. We like it from academic purposes because it does help us learn. So if you give patients drug therapy and then you remove the tumor, you can study how those drug therapies worked, the tumor response or lack of response. And then what is now an evolving field is if you see the tumor respond to a few cycles of therapy, you can really personalize the treatment, and it tells us a lot about prognosis, we think. So in some of the data that we've seen, if you have a few cycles of immunotherapy or targeted therapy and you have a pathologic complete response, so even if there's still something visible on scans, if you remove the tumor and you see under the microscope there's no viable tumor cells, that's considered a pathologic complete response. And the survival of those patients looks great. So if you went through this process and your tumor shows no viable tumor cells, you can see in the immunotherapy blue Kaplan-Meier figure here, 100% of patients doing well at the 24-month mark and very likely beyond, even greater numbers than if they received targeted therapy. So this really helps us guide discussions with patients. Now, if you didn't have a complete pathologic response, they might, as the data evolves, we might want to change therapies and not just stay the course with a year total of treatment of whatever the neoadjuvant therapy was. Here at Georgetown, we've been enrolling patients on a cooperative group study called 1801. where patients are randomized to either have surgery up front or undergo anti-PD-1 therapy, that's pembrolizumab, 3 doses, and then go to surgery. That trial is still enrolling, so we don't know the outcome, but we think this is a very helpful trial to learn from and may set the stage for standard of care management. So going back to our patient, neoadjuvant approach, the patient did enroll in this protocol, got 3 cycles of pembrolizumab. Restaging scans showed a very dramatic response. So you can see in this, the disease in the left axilla shrank by almost half. There's no new disease. Per protocol, the patient then proceeded with a left axillary lymph node dissection, and the pathology did show that there were more lymph nodes than just that large mass involved by melanoma, 9 out of 19 lymph nodes. The largest tumor was 2.5 centimeters. There was a lot of necrosis, meaning the tumor was broken down, and only 10% of the volume had viable tumor. So we consider this a major or partial pathologic response. We think these are the patients that are going to do very well, that the therapy is helping, and the patient currently has continued on the adjuvant pembrolizumab to complete a full year course, and we'll see how he does, but so far it's been quite good. So in the last few minutes, I did want to just talk about where we're heading. And I've talked about this in the past with some of the other medicine groups and some other presentations. And you may have been aware of me admitting patients to the hospital for TIL therapy. But there are a lot of immune therapy strategies evolving. And I think the TIL therapy is really close to being FDA approved and likely to be the next standard treatment that we offer patients. So adoptive cell therapy, or TIL therapy, tumor infiltrating lymphocytes, what we do is we take a tumor from a patient, has to be about 2 centimeters in tumor size, in the largest diameter. It's excised, it's processed in the lab, it's plated in cell plates, and the white blood cells, the T cells, are grown in the presence of cytokines, including IL-2, as well as other growth factors. Those T cells that invade the tumor are now expanded, and then they go through a testing phase where you test to see if they release interferon when they're exposed to the patient's melanoma proteins. That's called the ELISA spot assay. And it's really just testing to make sure those T cells react against the patient's melanoma. When they test positive, then we expand those T cells and create a large product. We grow them from thousands to billions. And they're frozen down, and then they're processed and prepared in a bag. It looks like a bag of platelets. Once that's ready, we bring the patient into the hospital. We give them a transplant regimen chemotherapy, and we infuse the T cells, and then we follow that by several rounds of interleukin-2. So this is quite a toxic regimen, but patients get through it. Think of it as on par with some of the transplant regimens that we use for leukemic patients. But patients can do quite well and tolerate it. We just have to make sure that they have good reserve. Sometimes we have to do stress tests and PFTs for patients to make sure they can get through the treatment. What we've now seen is that about 1/3 of patients with advanced melanoma who progress through standard therapy will have an objective response. And majority of those patients who have an objective response, it's durable and potentially permanent. And it's just a couple weeks in the hospital. That's all the treatment is, and then they go home and should fully recover. Just keep in mind, though, this can be a very toxic regimen. Over 97, well, in this study, 97% of patients had grade 3, 4 events. There's a couple of patients that had grade 5, meaning that there was a side effect potentially that led to death. So basically, every patient has something serious. It's hopefully very temporary. We can manage it and safely get them through it, but it could be thrombocytopenia, chills, pyrexia, febrile neutropenia, hypotension. So these patients require monitoring. We admit patients to tubeless on tele, and if they have any trouble, we involve our CCU folks and transfer the patient to the intensive care unit. So this is the group of us here that treated the first patient, still ongoing with various trials. You can see Dr. Al-Rafai, Dr. Sadawi, our pathologist, a surgeon and pathologist. That lower left-hand figure is the tumor that was removed. They dissected out the fatty tissue. And then this is the research team, me in the center, Stephanie, our research, and Dr. Queves in charge of our cell manufacturing facility here at Georgetown, off to the right of me. we had to ship the specimen off to the central laboratory where the T cells were grown. So we do that overnight in a special packaging. And this has now become a very, I think, proven therapy, and it's really just a logistical hurdle before it becomes FDA approved sometime, we think, later this year. So some take-home points: wide local excisions on a lymph node biopsy remains standard practice for patients that have T1B melanoma, so that's 0.8 millimeters or greater depth. The adjuvant systemic therapy should be offered to most patients with resected stage 3 disease. Nivo-Ipi continues to have the best survival data, so at Georgetown, that's what we offer most patients that have stage 4 disease or unresectable disease, even though it does convey the higher risk of immune side effects. The neoadjuvant immunotherapy is an emerging strategy, and we think this is probably where we're heading, that most patients that have high-risk resectable disease will first start with treatment, bring to surgery, and then based on that result, either continue immunotherapy or do some other type of treatment to lower the risk of recurrence. And then TIL therapy, tumor-infiltrating lymphocyte therapy, can produce durable responses in patients with anti-PD-1 refractory melanoma. And I think this is really going to be standard of care for patients. So we're about to have a really exciting treatment that we can offer. And it requires specialized centers like here at Georgetown. So you may be seeing this pretty soon on the inpatient floors. So keep in mind, and happy to work with any team, anyone who's interested in this. I can certainly really bring you up to speed and help engage you in the patient management.